The research is about electronic operation records within NHS, and particularly within a single centre, compared to what the whole practice in the NHS is like. Just to give a bit of a background before going into the research, good medical practice sets clear guidelines as to what is expected from any patient records. And surgeons, amongst other clinicians, must keep accurate, comprehensive, and legible records regarding all patient interactions. This includes, but is not limited to, any operative recording. There are a number of reasons why we thought that conducting this research is needed. First of all, to keep accurate and comprehensive records is essential for post-operative management of patients and for establishing good communication between the surgical team and any other healthcare professionals involved in the management of a particular case. But not only it is essential for communication between different specialties, it is also essential for medical legal reasons. There were a number of case reports, as I'm sure everybody is aware, where poor handwriting could lead not only to adverse outcomes, but even to the death of a patient. Royal College of Surgeons of England set a very clear guideline set about what an operation note should include. Not only it's very strict in terms of what components should be included, but also it advises that operation notes should be preferably typed. In my hospital where we did the research, we use an electronic operation note recording, which is called Blue Spear. This is just a set of guidelines set by the Royal College of Surgeons, which is what we used as gold standard in our research. The ideal operation note, whether it's handwritten or electronic, should include the date and the time. It should identify the patient. It should state whether this surgery is elective, emergency. It should give names of all the people involved in the surgery, including the surgeons, the anaesthetist. It should give appropriate details depending on the surgery. Should state any problems or complications, whether they arrived or whether they are not. And should give any details about any extra tissues or prostheses used in the surgery. In addition, it should give details about any blood loss, anticipated blood loss, real blood loss, antibiotic prophylaxis, and DVT prophylaxis. And finally, it should be signed by the person conducting the surgery, and should give clear details about post-operative care after the surgery for the patient. So we had a couple of aims with conducting this research. Primarily, we wanted to compare the clarity of electronic notes recorded on the electronic system used at King George Hospital with handwritten notes. And we wanted to compare how compliant they are and whether recording electronically is more compliant with Royal College of Surgeons guidelines compared to handwritten guidelines. And finally, to put the whole research into perspective, we collected some data on the type of operative notes used by the NHS trusts in the UK. So coming on to methods, it was a prospective review of 100 operation notes across all specialties at a single trust. Every day, 5 patients were selected from the morning session and 5 patients were selected from the afternoon session using a random number generator from Google. Cases that were cancelled were still included in the analysis, but the reason for cancellation was analysed afterwards. Data for each case was reviewed against the set of guidelines that we went through by a single reviewer, and when there were doubts about anything, a second independent reviewer was involved in the research. Compliance with the Royal College of Surgeons of England was defined as being good if it fell between 90 and 100%, fair if between 70 and 90%, and less than 70 was poor compliance. When we came to statistical measures in terms of comparing compliance with the guidelines between electronic and handwritten notes, we used Fisher's exact test. And the second part of research was to put our audit into context. We sent out a questionnaire to all NHS of England trusts, and we collected data on the type of operative notes they use and whether they use electronic or handwritten. And for electronic notes, we collected data on what specific system they use. So a total of 115 patients were selected randomly. The research lasted for about 2 months from August and September. 100 patients were included into the data analysis. The vast majority of cases were elective procedures, and only 10% were done under emergency theatre. The specialties that we covered included general surgery, trauma and orthopedic cases, urology, and 1 case from ophthalmology. Out of those that were excluded and did not go for an operation, there were 15 of those, and the most common reason for not going through with the operation was the DNA, so the patient did not come in for the elective procedure. Other common reasons included people were being unfit, unsuitable on the day of the operation, and 3 of those were excluded and were not performed because of the time pressure. So a total of 22 notes out of 100 that we included were completed electronically. The remaining 78 notes were completed by hand. And out of those handwritten notes, more than a third of those notes were very hard to read, very hard to understand, and required a second independent review by another junior doctor involved in the research. Out of those notes that were hard to read, majority belonged to urology, 2 to general surgery, and a couple to trauma and orthopedics. Despite the attempts of a second independent reviewer to try and understand the handwriting of those urological notes, 2 of them but still remained unclear, and required a third independent review and still remained unclear. This is just to give you an example of what we use at our hospital as a preset performer of a typed electronic surgical operating notes using Blue Spear. It goes without doubt that everything on it is clear. We didn't struggle with any of the electronic notes. This is just another example, and this one is slightly different and gives details of a prosthesis on the second page. The handwritten notes, they ranged in terms of how clear they are. Just again, to give an example, this one only required 1 reviewer to read. Again, it's very subjective, but this one is one of those that was deemed to be easy to read. A couple of urological notes, such as this one, were very hard to read. We couldn't really understand most of the handwriting, despite 2 or 3 people independently reading it from different specialties, from different ranks in their degree. This slide just gave a summary of the results. Unfortunately, not a single operation note met all of the guidelines. The only thing that I wanted to draw attention to is the antibiotic prophylaxis. This is the only component of the guidelines set by the Royal College of Surgeons that was met statistically better when recorded electronically compared to handwritten notes. There are a number of areas of good compliance for both handwritten and electronic notes, such as date, patient details, name of the surgeon, and a couple of areas of poor compliance, including DVT prophylaxis and antibiotic prophylaxis, amongst others. So as I said, when we tried to put everything in a statistical perspective, electronic recording was better at recording antibiotic prophylaxis only with a p-value less than 0.05. And there were no statistically significant differences between handwritten and electronic recording in any other component of the operation note. Coming on to putting this into perspective and talking about all the NHS of England trusts and what they use, we sent a questionnaire to 148 NHS England trusts that had emergency and elective surgical care provided. Unfortunately, quite a small number of trusts got back to us. 31 out of 148 responded. And out of those 31 trusts, more than 50% use electronic documentation only. 6 use both handwritten, 7 use both handwritten and electronic, and 6 only handwritten notes. It was quite interesting to see, we had 31 trusts responded to our questionnaire, and we identified about 25 different electronic theatre management theatres. This table just highlights the variety of different electronic systems employed. So out of those trusts that use only electronic systems, the most popular was Cerner Millennium, and the second popular being Epic EPR. And the second part of the table highlights trusts which use both electronic and handwritten, and one of the more used ones is Meditech. It was also interesting to see that a couple of trusts wish to build up their own in-house system. For example, EPR and clinical results reporting system is a very specific system, only specific to the trust used by it. It's not nationwide, it's very individualized. So there are a couple of discussion points coming from this research. The first one is we're not very good at keeping up with the Royal College of Surgeons guidelines in terms of compliance to specific components that should be recorded on an operation note. And the second point being about the heterogeneity of the different IT systems used by the trust. Despite sort of digital area being 2020, majority of the trusts still prefer handwritten notes to electronic notes. And 25 different systems used by 31 trusts just highlight how trusts prefer to use individualized systems, which creates a number of problems, especially when people are rotated from trust to trust, costs of training the trainees to use different systems, and it's just becoming very difficult to transfer information between the trusts. So a number of recommendations. First of all, to increase education on the guidelines set by the Royal College of Surgeons. We displayed those guidelines in theatres, we delivered this talk to the trainees. We are running a second cycle of the audit just to see whether this improved compliance with the guidelines. And the second point, we thought it might be useful to standardize the layout of electronic operational templates. For example, maybe use sets which you have to fill with before you can move on to the next component of the guideline. We sort of talked to the surgeons that prefer handwriting to electronic, and the common bottom line of the problem was that the functionality of the systems employed are not very user-friendly. For example, a large proportion of both handwritten and electronic notes in our trust, about 40% each side, including a handwritten diagram of either the incision of the findings. And the surgeon said it would be nice if the electronic systems could have templates of the most common operations, which they can use or adopt from simple softwares like Paint. So we thought creating anatomical drawing templates that could be pasted onto the operation note could be useful with an uptake of electronic notes. Obviously, there are a number of limitations with this study, the most obvious being a small data set. Because we included every single specialty at King George Hospital, and the data set was quite small, there was not enough data to evaluate which teams have started taking up electronic notes. We thought that some of the data points from guidelines are a bit ambiguous. For example, if the operation is not diagnostic, they might not include operative diagnosis versus findings on the paper. And we thought it was quite subjective in terms